My name is Liz and I'm a member of the clinical education team, and today we're going to look at how to make a complete evaluation for a prescribing clinician for a patient with a diagnosis of paranoid schizophrenia. This note would be similar, can be used for clinicians in either the inpatient or the outpatient setting. Let's come over here. I'm in the chart face for my patient, Brian Jones. This is the very first note that's going to be made for him. And I'm going to click on to complete assessment. I'm logged in right now as an MD working in the outpatient setting, but this, like I said, this video could be used for the inpatient setting as well. And it says here, Mr. Jones is a 49-year-old man. His chief complaint is, and I've already created a custom button for a chief complaint for a patient who's paranoid. We're going to come over to the symptoms area and go down and work in the psychosis shrub. We're just going to work our way down here so you get lots of good E&M coding credit. Information was received from the patient and also the family. The patient has a psychotic process and is exhibiting symptoms. Is there a precipitant? And I'm going to say yes. The patient or the family says this patient has a history of mental illness. What are the timing of the symptoms? They're recurrent and happening daily. The onset of the symptoms have been insidious over the past couple of weeks. Symptoms described by others. Family says his behavior has become increasingly bizarre. His affect shows inappropriate anger. He has paranoid delusions. The symptoms that the patient is personally describing to us today are persecutory delusions. Okay, let's go back. We're going to concentrate just strictly on psychosis today. Skip over these other areas. I'm going to say that this patient's symptoms are of high complexity right now, and he currently denies any depression. Of course, ICANotes makes it easy for you to say that the constitutional and the musculoskeletal systems are normal, if indeed they are. Let's come forward and go into the past psychiatric history. And this information, once again, was received from the patient and the family. He has no history of withdrawal. He has been hospitalized more than once. The age of the first hospitalization was in his 20s, and the reason for the hospitalization was because of psychotic symptoms. Also unsafe behaviors, including destructive or aggressive behaviors that were present at that time. He's also received outpatient treatment. He is receiving that, and the condition being treated is his psychosis. Medication is prescribed. Okay, let's come down and talk about whether he's currently suicidal or self-injurious, and then let's just say that he's having suicidal thoughts right now. Is he assaultive? And I'm going to say he's never been assaultive. Has been assaultive. I clicked the wrong button. Mr. Jones has been assaultive. If you do that, just simply erase the sentence that's generated and click the button that you intended to click, which was never. Mr. Jones has no history of assaultive behavior. He's not a substance abuser, acting out behaviors. Maybe he's having some night absences. Medication compliance, there is a history of non-compliance. Psychotropic medications, he has been on Zyprexa in the past. I'm going to drill down here and click on that, and I can put down the patient's response to it. He says he stopped taking it because it was too expensive. Okay, I could have also come down here if he had been taking Zyprexa and had a good response. I could have detailed that right here. Okay. He has not failed monotherapy. There's no history of failure. Prior psychiatric disorders and prior care history we're going to skip over for right now. Let's move over to his medical history. And just to keep this pretty short, I'm just going to say that his medical history is negative at this time. I do want to put down that he has no history of adverse side effects or drug reactions and no known allergies. Okay. I might also want to say that his cardiac disclaimer. Let's go over here to the social history. It says here Mr. Jones is a 49-year-old man. As a psychiatrist, we're just going to stick to the high-risk psychosocial behaviors right now. And I'm going to say that, for instance, family negativity may be at present and putting him at risk for noncompliance with mental health services. You might ask him if there's weapons in the home, and he says no, there are none. There's lots of other options that you can go into, or this can be filled up by the social worker, the social history area. We're not dealing with a child, so we'll skip developmental history. Under family mental health history, I'm going to say that he has a brother who carries a diagnosis of, let's see here, unspecified emotional disorder, and that he also has a cousin who is thought to have alcoholism, and this cousin is on the maternal side of the family. Otherwise, the family history is negative. Let's do a quick mental status exam for a patient that is acutely psychotic. We'll start with appearance, and I'm going to say that he is guarded, wary, minimally communicative, disheveled, and aloof. His speech and language are both normal. His mood is euthymic. His affect is not normal. I'm going to say he has inappropriate anger. Come back. Associations are not normal. Let's go into the list. And I'm going to say that he is illogical right now. And we'll come back. There are symptoms of psychosis or psychotic features, so we're going to go into the C list and select the first button. It gives us an opening sentence here. His behavior is bizarre. He's not having any hallucinations right now. He has an inappropriate affect, inappropriate anger. Delusions, paranoid delusions are present. And once again, his associations are illogical. And we can go back. He's not homicidal. Cognition, baseline is normal. IQ is above average. That's his baseline. Insight is poor into his illness, as is his social judgment right now. He does have signs of anxiety. Let's go into the C list and say that he is irritable. He has an exaggerated startle response. Okay. Under attention span, I'm going to say that he is distracted and that his behavior is somewhat defiant and with poor eye contact. He does not seem to be withdrawing from drugs or alcohol, so we can skip that. There are additional areas that you can go into under the mental status exam. There's a physical examination, the AIMS scale. You can do a constitutional exam, which includes vital signs, which you would probably want to do in an inpatient setting. You can also do an examination of the musculoskeletal exam. But for right now, I'm going to move forward into the finish initial, and we're going to add one medication for him. I'm going to click open the enter area, and if I'm going to prescribe this in an outpatient setting, I'm going to work all the way across. If I'm in an inpatient setting, I'm just going to fill out the first 5 fields, knowing that the medication, when I compile the note, will push into my MAR. But let's go ahead and get him started on, say, Haldol decanoate, 300 milligrams, IM every 4 weeks. If I was printing this out, I could go ahead and fill out this out all the way across. You could even do the start date if you wanted to start it on a day other than today. I'm just going to put in here for right now that he's getting this for psychosis. Once again, I could click here to print out the script, or I could leave as is if I'm in the inpatient setting. I'm going to click done. Here's our medication. Under instructions, recommendations, and plans, let's come in here. Let's say if we're treating him in the outpatient setting, I can come here and click this. Treating him in the outpatient setting. We're going to be doing some crisis-focused interventions with him, also some psychopharmacology. You might have talked to him or his family members about the risks and benefits of medication, including the Haldol deck. All right, that information went right here. As a prescriber, you don't need to fill this in. If you want to put in the start and stop time, that's fine, but you're not obligated to from a coding standpoint. Our medical history is pulled forward, as has our notes and risk factors. You can do a suicide and violence risk assessment. I'll leave that for right now. We're not doing any therapy. Let's go ahead here and put in a diagnosis. And I am going to blow this up so you can see it a little bit more easily. And we're working in ICD-10. I don't know the code by heart, so I'm going to come in here and search for it. I'm going to search under each of these 3 areas to come up with my diagnosis. All of the mental health or behavioral health diagnoses are listed under the F codes: mental, behavioral, and neurodevelopmental disorders. The schizophrenia, schizotypal, delusional, and other non-mood psychotic disorders are on the F20 through F29. Let's select that line. And then I'm going to come down here and say that for right now, his diagnosis is paranoid schizophrenia. Okay. You could make this a rule out by clicking right here if you wanted to. You could update it later. By the way, you can also always update a diagnosis if you need to in the future. You're welcome to put in as many psychiatric and medical diagnoses as you want to. I'm just going to take this out and make it a little smaller for us again. All right, so here's our diagnosis. If I'm in the outpatient setting, probably want to see this patient in, I'm going to say 1 to 2 weeks or earlier if needed. And I'm going to go ahead and code this note. This is going to generate an outpatient code for us because I logged in under an outpatient setting. Okay, and the code it gave me was a 99203, which is an office code for a new outpatient. I'm going to go ahead and compile this note. Okay, and like all complete examinations, the program's going to ask you to title it yourself. I'm going to say this is a complete examination in the outpatient, but if I was in the inpatient setting, I could definitely do that too. Outpatient setting, and it was done by the psychiatrist, or if you want to be more specific, you can put down your own name with your credentials. Click continue. Here's our note. You can say that this is a very detailed note. It's easy to read. Uses the correct first name, pronoun, possessive pronoun. It has a signature line on the bottom. To make it a legal document, I just have to electronically sign this. And I'm going to go back to the patient's chart face. And here is our complete evaluation for Brian Jones. Notice the diagnosis has come forward. Haldol Decano weight has come forward. The notes and, the adverse drug reactions, the fact that he doesn't have any, and the notes and risk factors.